I'd like to invite Dr. Lanre Olayiwola to tell our story in the 4Gates project. Thank you.
Let me start by saying I'm here to tell the story of the efforts of the commitment, dedication, and resilience of over 200 men and women who worked tirelessly over the past 5 years, not minding their life and the risk that what they do get them into towards achieving the goal of epidemic control in the state where we are assigned. I also want to submit that for us in CCFA, we are aware that there are many rivers we have to cross. There are countless hurdles we have to doubtlessly climb. For achieving epidemic control was our pride and passion. And from the story you will hear shortly, you will be able to tell whether we were able to do that or not. Riding on what my boss has said, I want to quickly tell you that I'll be following the outline you see on the board and not wasting much time. As a way of introduction, we are Catholic Caritas Foundation of Nigeria. We are also called Caritas Nigeria. We have an organization that is created by the Catholic Bishop Conference of Nigeria. And even though this, the humanitarian intervention of the Catholic Church has started long before 2010, Caritas Nigeria was incorporated in 2010. And it has been involved in implementing HIV program in the country among the Committee of Implementing Partners as far back as 2012. But we're not just at the HIV implementing organization, we're also involved in other interventions. We're involved in emergency response and humanitarian services. We're involved in agriculture and livelihood, good governance. We also get, support the nations at various times at various parts of the country on anti-human trafficking and irregular migration, as well as institutional capacity building. Having talked about the CCFA, I want to quickly tell us what the 4Gates project is all about. 4Gates itself stands for Global Action Towards HIV/AIDS Epidemic Control in Subnational Units in Nigeria. It's a comprehensive HIV care treatment program that was implemented, by 4 consortium partners, and of course across 4 states initially, and well over time it has remained 4 states. What you'll be wondering is, what will have Global Action Towards HIV Epidemic Control? Where is the 4? The 4 stands for the consortium partners implementing 4 strategic objectives in 4 states across the country. And what was our mandate when the 4Gates project started? We had a clear cult mandate, and we have a overarching goal, which is to achieve epidemic control in SNUs, that's subnational units in Nigeria. And like I said earlier, there are 3 cardinal strategic objectives that we set out to implement, as well as to support the government of Nigeria, faith-based organizations and other civil society organizations to demonstrate improved stewardship for the delivery of the comprehensive HIV program. Now, talking about where we work, we started with 4 states, and the 4 states, Delta had an HIV prevalence of 1.9%, and there were estimated over 64,000 persons that are living with HIV in Delta state. Then the second state is Enugu state, with a prevalence of 2.1% and an estimated PLHIV population of 55,000, slightly over 55,000. And then we have Igbo state. Igbo state has a prevalence of 1.9% and an estimated PLHIV of nearly 62,000 persons. And at a point in the life of the program, we have a Ebonyi state. So we implemented in the Ebonyi state up until the 3rd year of the grant, when the Ebonyi state had to be transited to a global fund partner on the National Alignment Program. And in the last year of the grant, we were assigned to support Abia State, which was initially a state supported by the government of Nigeria, and towards aligning programming in Abia State to achieve epidemic control. When we started the 4Gates project in 2017, it was meant to be business as usual. We were supposed to, implement in 4 states, and the 4 states we assigned to work were some state support states. There were states where intensive, activities were not expected to be carried out. We were expected to do minimal testing, focus on in-facility testing, as well as ensure that quality comprehensive service delivery were provided in those states. However, something's changed. In March 2018, after the release of the National Health and Indicator and Impact Survey, we had the SURGE program launch. And the launching of the SURGE program happens to be the game changer. The programming intensity changed across the country, and after this recalibration of the national epidemics, where the 3 states of Delta, Enugu, and Imo states were classified as red, where intensive activities to accelerate HIV case finding and attain, linkage and attain retention and sustain suppression was launched. This was underscored by CIRAS. CIRAS is Comprehensive Integrated and Resilient Hierarchy System. I want to say here that as Caritas Nigeria, we implemented CIRAS with high fidelity. And you can see that CIRAS was actually at the center. You see the 5 core principles, operating principles, as well as the 10 essential components of CIRAS. Across board, you see in the course of the presentation that we took all of this to scale, and it helped us to achieve the needed success that we desire. Let me start by telling you that upon the declaration of SURGE, the first thing we did was to do SURGE launch across the 3 states where we are implementing SURGE. And you can see this involve a high-level advocacy including the US Embassy at the highest level. And then this also gets governors in the state. You can see governors of Delta, Enugu, and Imo states, carrying out, SURGE launch. I want to tell you that this was a very landmark activity at that period because, declarations were made that helped us to drive the HIV program. We also formed the SURGE consortium. You can see traditional ruler there. And these people played a pivotal role in ensuring that we were able to carry out all the activities we set out to carry out in those states. In fact, I need to say that the SURGE consortium was a very important component of all that we did across the states. This is the incidence command system. And you can see the structure of our incidence command system. From the HQ, we have, this structure cutting across different levels. It is a military approach, and it was quite intensive and very tasking. This was the way it is in the state. But what is important on this slide is the stratification of our sites to the different layers of tiers. The Pareto principles was applied, so you have tier 1, 2, 3 sites, and these sites were actually supported based on their level of productivity and capacity to produce results. Index testing was, was core, and it helped us to be able to, accelerate case finding and help us to achieve humongous targets that ordinarily would have been difficult to achieve in, other situations. And then you can see some of the strategies that also come to play. For us in CCFN, we have to go as far as procuring a boat to be able to cross to the creeks, because we believe that no one is hard to reach. People are only hardly reached. And on that account, we did everything possible within our power to ensure that we reach those in those difficult terrain. You can see our widow strategy, and you can see we went as far as getting to the traditional killer school. For our second 95, you can see here that clearly all the strategies that have been proven and tested were brought to scale, and of course the results will soon be seen that show for it. Ditto for our kit at third 95. At third 95, of course, you see today that among the committee of IP, we also recognized for achieving viral load suppression in the least expected subpopulation, pediatrics and adolescents. Then let's quickly look at the results. This is Delta State when it started. The estimate of people who are living with HIV was 64,000, nearly 65. The PLHIV on treatment then was just barely 25%. Treatment gap at 48,000. What's the story looking like now? We have 74,000 people on treatment, far above the number of estimated gap. And now we have about 115% health saturation. Not only that, we also ensure that viral suppression is within the acceptable benchmark. The coverage and the suppression you can see. Somebody may be asking, where are the extra coming from? The reason is because the denominator for the estimate is the spectrum estimate, which is strictly a derivative of the population we are referencing. However, the numerator for the ART coverage is the TS score, which does not necessarily mean that all of the people that are taking treatment in the state were all residents of the state. So you see that for Delta State, and I need to show you how we got there, the trajectory we took from the beginning. You saw the inertia, and how we move on. It is my Enugu State. This is what it was before. This is what it came up to be. 31% at start, at 26% now. And then you see it, the trajectory we took, and how we got here. Then for Imo State, it was 24% coverage at on ART at the start, now being 118%. And you can see what has happened to viral load coverage and viral load suppression over the time under review. And then this is the trajectory again. It was a upward trend. And then in Abia State, but it's important to say that Abia State has only implemented for barely 12 months because we took over the state in the last year of the project. However, even at that, we are able to achieve 72% ART coverage, and you can see what the viral load suppression looks like. And then this is our trajectory, how we got there. We're not just reading out number, we also have pieces to our story. And then you can see the story. Here is a little girl, an orphan, 8 years old, who was tested HIV positive, enrolled in the ORB program. I was weighing 30 kg at start. I went at baseline, and the BMI of 11. Viral was about 3 million. This is the same girl after the intervention you see above, and then you can see clearly that the child has changed tremendously with an unsuppressed viral, not detectable even. And then the weight has come up to 55 kg for 30. Here is another case that also put a face to our story. You see a 14-year-old positive child who also had a lot of challenges, dropped out of school, and they had to be admitted in the hospital because of severe illness. And this is the same child after intervention. And you see all that has changed with the intervention. So, but this is our story. And I thank you all for this.